Okay, are we ready?
We sure are.
Okay, so everybody should be able to see our opening slide that is going to remind us why we're here. It's October and it's Dysautonomia Awareness Month. And in celebration of this, we've united with Dysautonomia Louisiana to have a special evening tonight with Dr. Patel. And we appreciate you coming so much, Dr. Patel. We know it's been a hectic day, week, month, year. Your life is just always super busy. So thank you for sharing this time with us. As our presence shows you, there are so many people here who are anxious to hear what you have to say, your words of wisdom. We'll be going from 7 till about 9 tonight. We asked for pre-registration of questions. We didn't really have any, so we're going to have something at the end where you'll be able to have a chance to respond to what Dr. Patel is saying. The agenda for tonight, first, we're going to do a brief overview of Zoom. We obviously still need some refresher. As you can see, we're having a few little glitches there. Then our disclaimer about this being not medical advice coming from us. It is our experiences. You should consult your own professional doctor, and that this will be recorded. A little bit about EDS Louisiana. Then I'll introduce April, who will introduce Carmen and Dr. Patel. Then at the end, we'll have our questions when you raise your Zoom hand. So let's take a look at some of the things for Zoom. Is everybody able to see my slides first off? I want to make sure that that is something that you can see easily. And you are all muted. If you want to speak later, you know how to unmute. If anybody has any questions, just raise your hand at this point and ask us how to do it. There's a chat feature down at the bottom. We're going to go over quickly. Whoops, wait, hold on. Just so that you can talk to each other, but make sure that you're putting the right person on there that you want to be speaking to. And some people do get distracted easily during the talk and don't want to be chatting, and they may turn it off. So that may be why they're not responding. But that's where you'll be able to put your questions or ask them live. We're asking that you please make sure you're in an area that is private, that no people are walking around because we'd like to protect the privacy of everybody, although this is being recorded. So when you do ask your questions, please make sure they are not full of private details, but are something of a general nature that would benefit the entire group. Anybody need any help with Zoom? Everybody's doing okay? All right. We've all gotten pretty proficient at that with COVID around. This is our medical disclaimer that EDS Louisiana and this whole support group, which is we meet on these Thursday nights, and we decided to have a speaker tonight so that we could learn more about dysautonomia. We are not healthcare providers. Dr. Patel is, but we're not, and we don't provide medical advice or treatment. He's not providing treatment for an individual person tonight. It's just general information about dysautonomia. It is for support purposes only. It's not a substitution for your medical care. You know, people who say, oh, well, I take this or that, we need to say that is what I respond well to. It may not be for somebody else. And nobody here who is speaking can be held liable for misinformation. Please, please, please talk to your own personal health care provider about your personal healthcare options, differentiated just for you, because everybody here is unique and wonderful, and we want you to have the best health possible. All right, so a little bit about EDS Louisiana. I am the executive director right now, and April Torres is our founder. We have a board of directors that is composed of Gilbert Torres, April, Angel Painter, and John Furman. And we are blessed to have Dr. Patel as our medical director. Thank you so much, Dr. Patel, for sharing time out of your busy schedule. We also have Dr. Corso and Dr. Cram as some other advisors. We offer support groups. We have our monthly support group meeting on the Thursday night at 7 o'clock, second Thursday of the month. We have coffee socials where you bring your own coffee, and it's Zoom for right now. We hope to go in person once COVID calms down a little bit. Although we're glad that we can reach so many people who wouldn't be able to drive in. We have a statewide monthly support group meeting for the men that has expanded out to be a national group now. We also have a tweens and a teens group, and we're looking to start a caregivers group if there's the interest in our members to do so. We are growing rapidly. Right now, we have about 650 members, which is just astonishing from the time that April started just a few years ago when she saw the need. I'm getting reverberation. Does anybody else hear that, or is it just on mine? That's better. Okay. Thank you so much for adjusting that. Everything is still virtual, but we're hoping to get back to meeting in person as soon as we can. We are trying to bring awareness and information throughout the state. Our mission is to provide support and resources. We know how much we need it here in Louisiana, and we hope to help as well the medical professionals learn more about Ehlers-Danlos syndrome and all the related conditions, and hence this meeting tonight. We're trying to bring about the awareness and education. Our vision is a better Louisiana, where we're fully understood, treated, and supported. And we thank Dr. Patel for helping us out with that. You'll hear about many opportunities where you can possibly volunteer and help bring that awareness and education throughout Louisiana. Our volunteer coordinator is Mary Ann Joffrey, and she'll be posting things soon about some wonderful, exciting volunteer positions that are available. So stay tuned for so many other great things. All right. April, would you like to
Sure.
share with everybody? April Torres is our founder. She lives in Rain, Louisiana, and we are indebted to her for having a vision of creating EDS Louisiana.
Thank you so much, Mona. We appreciate you so very much. Like Mona said, I am April Torres. Just a small little bit of a background information for anyone who may not know me yet. I'm a registered nurse, and I'm a published author. I struggled severely for many years, not understanding what was wrong with my body. And before I ever even heard the term dysautonomia or EDS, Ehlers-Danlos syndromes, I found myself in a very lost place without any support. And if you'll excuse me, my computer wants to die right now. Perfect timing. Okay, so I found myself in a very lost place without any support. And of all of my amazing family members, no one quite understood how sick I was truly becoming. Once I became educated and aware that these conditions existed and were the answers to all of the questions that I had been searching for, I became very passionate, especially with being a nurse, not having ever heard of these. This brought a very deep conviction within me to get the word out, educating and spreading awareness so that other Aprils and other Monas wouldn't have to endure such long struggles, feeling so alone like I had. It didn't take long before I learned the name of a cardiologist named Dr. Umesh Patel in Covington, Louisiana. The word was going around that he was the doctor to see. And by this time, I had already started EDS Louisiana. And on my first appointment with him, I brought him a stack of my business cards explaining the support groups that we were starting around Louisiana. And as I shared my own story with him, I was really vulnerable with him. I wanted him to know how far I had come, along with my passion to see to it that no one else has to struggle alone. I encouraged him to send anyone in need of support that he comes across with dysautonomia or EDS our way. And not long after this, he connected me with another young lady who he claimed may be helpful to join forces with. She stands with us today, and we are very proud to have her here today, representing Dysautonomia Louisiana Incorporated. Her name is Carmen Gonzalez, and boy, is she a go-getter. From the moment I met her, I stood amazed at her ability to stand before parish councilmen and women as she caused grown men to lean forward, listening to her every word. She has been pounding the pavements for years now, seeking out proclamations, going from parish to parish, requesting proclamations and educating our parish leaders about dysautonomia. I present to you now, without further ado, Miss Carmen Gonzalez. Carmen?
Carmen, you're muted. We can't hear you.
How many problems can we have in one night?
All right, you're not the other one, Dr. Patel. Yeah, anyway, well, let me rethink what I was saying. You didn't throw me off track. Anyway, thank you much, April. I appreciate that. I recognize a lot of you faces, but more than faces, I recognize these names. I've seen y'all post and on our awareness site, and I'm so glad to be able to put a name and a face to some of you ladies and gentlemen up here. But a little about me. I fell ill in 2009, and was just right before my 40th birthday, and it was like somebody unplugged me. I had no inclination of what the road was going to be like ahead of me. I was in and out of the hospital for 2 years or 3 years. I was 28 trips to the hospital, 3 heart surgeries, a life flight. They finally transported me from East Jefferson Hospital here in Louisiana to Nashville, Tennessee. And in one day, I got a diagnosis of dysautonomia. And I was livid. I said, there is just no way it should take 3 to 5 years to get a diagnosis. And I can't be the only one in Louisiana. So I came home with this diagnosis, and I was able to get enough treatment to be able to get my feet underneath me and start Dysautonomia Louisiana. And so the first thing I did was apply for a proclamation to get the state of Louisiana to recognize Dysautonomia October as Dysautonomia Awareness Month. And we've done that since 2015. And then I decided I was going to get a proclamation in my own parish and start raising awareness here. And then from there, I thought, why not do all 64 parishes? There's got to be other Carmens out there. So I've done about 25 when I realized every October I'd go out and raise awareness, and I'm meeting all these wonderful people, and I'm getting all these proclamations and doing awareness days, and I am killing myself at the end of October that I could not do this by myself. So I had met some wonderful women along the way, one being Ashley Parrish from up north Louisiana, and then Amy Forte from here in the Mandeville area. And we decided between the 3 of us, we were going to make Dysautonomia Louisiana a nonprofit, and we were going to raise funds, and we weren't going to do this by ourselves, and we were going to make it happen. And with plenty of help from Dr. Patel and a handful of other ladies, we've successfully done awareness events in 37 of the 64 parishes. And my goal is to have all 64 parishes done by 2025. But then COVID came along, and then we couldn't do awareness events like we were doing, and they'd shut down all the parish offices. So everything's done on Zoom, which threw me for a loop because I'm not a Zoom person, and I don't do social media very well. I have a rough time just keeping up with my own Facebook. So we regrouped, and we decided to create a website. And then through social media and through the website and through just talking with people more in an individual basis, I realized that I was so focused on awareness that I had met well over 700 people with dysautonomia, and those 700 people was still struggling. So we looked back at 2022 and realized we really don't need to be going out getting more parishes. What we need to do is stop and help the 700 people that we have on board. So this year we've refocused what we're doing, and we're focusing on bringing together and helping the people on the things they need help with. They need help with getting prescriptions filled, getting a diagnosis. They need help with finances. They need help with social work. So this being the very first Zoom meeting of this month, if some of you follow the Facebook page, we have 3 other Zoom meetings scheduled. The first one is going to be with BioCommand, which is by Christy, and she's a hypnotherapist. And you think, who wants to be hypnotized? I want to be shot into another world and come out in a new body, but that's not going to happen. But hypnotherapy can help us get into our subconscious mind, and she can help us find that healing point, because dysautonomia is not really a death sentence. So we have to learn to live in the body that we're in and try to calm that autonomic system down. So she's going to be a big asset to us to help us talk to our brain and kind of settle it down and learn to live in this new crazy world that we exist in. Then the other Zoom meeting we have is Dr. Holly. She's a clinical social worker. She's going to teach us some coping skills to be able to, I mean, dysautonomia doesn't only affect the individual, it affects the whole family. So we have children, we have spouses or boyfriends or work, we have stress, and she's going to help us walk through some tips to learn how to adjust our lives, because dysautonomia is life-changing for many of us. And then the third Zoom meeting we have scheduled is with a financial advisor. Now, what does that have to do with medical? But I don't know about you guys, but my world went a whole lot different than I expected. And I retired 15 years early than I expect to retire. So then what do you do when you're coming out of a career and you've got 401k? Do you spend all your savings? How are you going to pay your bills the rest of your life? How is my money going to last me? What do I do when I get Social Security? How do I get Social Security? What kind of end of life plans do I need to make so my kids can financially take care of me when I'm old and cannot function any longer on my own? So he's going to answer a lot of those financial tips and help us get through budgeting in today's world and plan for the future. And that one will be on the 27th of October. All of these Zoom meetings that we're talking about, just like this one, is posted on our website, and you can just email us and we will send you out the link to get on. And you can ask any question prior in advance. You may have a specific question you have for a social worker or for hypnotherapy or for our financial. Just shoot those messages to us. We'll make sure that they get them. But the other thing that we're doing too is we have an awareness day on the 17th of October at Ochsner's Hospital main campus. It's open to the public. Anybody can come between 9 and 3 and visit with us there if you're in the area. We always welcome you to the hospital awareness days. And then we have a private event at Nunez Community College. We've been able to partner with those guys, and we're going to do a seminar and awareness to the medical graduating class on the 17th. So that's very exciting for us to be able to get these new doctors and nurses, and right before they go out to do their residency, to get them aware of dysautonomia from the get-go. And we're hoping to do more colleges. And today I met with broadcasting of Southeastern University, and we're going to be doing a segment with those guys. So I'm excited to do some broadcasting through their university up here in Hammond. So we've got several things going. We do have 1 or 2 little proclamations. Franklin Parish has now granted us a proclamation, so we will start doing awareness days there. Guys, I can say this, we run by volunteers. None of us are paid to do any of this, and all of the efforts that we do are strictly for the benefit of our members. If anybody has any time to volunteer, whether you're doing data input, whether you're calling parish officials, whether you're just creating our awareness ribbons, those are wonderful. So we appreciate you all coming here today. And without boring you anymore with the long story of Dysautonomia, Louisiana, I'm going to introduce our host, Dr. Patel. But before that, is everybody ready to take a picture? Let's get our little shirts on all straight. Everybody fluff the hair up nice. Okay, we want to look as good as we feel. No, we actually want to look better than we feel. So I don't know who's taken this photo, but let's see. if I can manage that. So do we technically have to do all 4? Where you at, April?
I'm actually going to go back and forth. It seems like the last 2 and 3 pages are those who are choosing to not turn their cameras on for whatever reason. That's totally fine. But the ones that do want to be included in the turquoise, let's just make sure that we can see, number 1, see our turquoise. Good job, Fiona. Okay, guys, let's see. Oh wait, what is going on here?
I'm late, but can you see me?
Yes, Shelley. we
Miss
can
Shelley,
see.
we sure can.
Okay, because it looks fuzzy from.
You have
from-
lines going through you, but that's okay. We're looking through blinds at you. That's all.
That's
Okay,
okay.
I'm like, it's messy.
If you want to lower your monitor just a little bit, well, now we see the beautiful picture of you.
Oh no, I want it to be live. I don't know what's happening.
There you go. That's good.
Okay.
We
Okay,
can
maybe
see
that's it.
we can see the turquoise better this way. So,
Okay,
all right, 1, 2, 3. Who wants to say cheese?
Jeez.
geez.
I'm gonna just do a few, and then I'm gonna after we do this one, I'm gonna switch over to, this is page 1 of 3. Let's see if there's anybody here. Oh, look at y'all. Hey, Stephanie. Hey, Lynn. Hi, Amy. Hi, Kathy, Barbara, and another Barbara, Lainey, Lindsay, Mary Lynn. Okay, let's see here. Jennifer Trey, there you are. Lovely hairdo. Okay, I got a couple of pictures of y'all. Amy Forte, beautiful picture. Okay, let's see, let's go to the next one. And it looks like we have the same people still on here. We're still gonna go for it. Smile, everyone. 3, 2, 1, smile. Okay. So we right now, just to let you all know, we've got a total of 57 people present, which is amazing. So we're so thankful for that. So Dr. Patel, are you still here? You're on mute though.
Finish taking your photos, April?
You see me
Yes,
now?
I'm finished taking the photos. And so if everybody will go ahead right now, every single one of us, if you don't mind pressing mute, just in case there's some back, I can't think of the word, sounds in the background. So we can hear Dr. Patel clearly. And Dr. Patel, the floor is yours.
Well, thank you very much, everybody, for such a wonderful group meeting. Thank you especially to both April, and I see your names, I know most of you, and it's pretty impressive. I didn't realize there'll be so many showing up. Anyway, I just a quick apology. I was planning on doing a little special talk and everything, but life has been crazy. So here I am. I'm going off the cuff and just telling you how it is. So I'll talk a little bit, and then I'll be more than happy to go over any questions and so on in the general fashion, as we already said here in public. So just for those who may not know me, or what I've done and so forth, a quick intro. I was educated at University of London in England. I'm double boarded in England in both family medicine and OB. I've actually delivered babies, would you believe? So the local gynecologists seem to have a lot of confidence in their dysautonomia patients coming to see me. And then I came to Tulane and I did internal medicine and cardiology. And so, after basically 10 years of specialized training, went into practice. And over the course of the last 43 years, I've kind of gradually realized that we see so many people coming in with symptoms that they didn't actually tell us about in the textbook of medicine or when we were training. And they're all put in these little pigeonholes that, well, if they have, for example, chest pain, shortness of breath, palpitations, you do these tests, and if they're okay, then bye-bye, there's nothing more to be done, and just pat them on the shoulder and say, you're fine. And, over the years, I realized this was not good, because I was getting lots of patients coming in, seeking help, and being told, well, there's nothing, it's normal, this is life kind of thing. So eventually I put it together. There's probably something connecting all the systems. It's not just the heart. It's actually more than that. It's the brain, the lungs, the gastrointestinal tract, pelvic organs, and so on. And the one system that really does connect everything together is the autonomic nervous system. So digging into that, I kind of gradually got more interested, and lo and behold, along comes Carmen and April, and now I'm swamped with everybody seeking attention. Now, I'll be totally honest with you all. There are quite a lot of very smart doctors who do the research, and they give me the information I am using. I'm a practical kind of doctor, okay? You come to me and I'm like trying to help you get back on your feet. So, originally I was going to do some detailed stuff. I said, you know what, we just need to go ahead and let everybody know the basics of how we have to take care of you. Number one is so important, is to acknowledge that, when you have multiple illnesses, it doesn't automatically mean you're being taught to physicians that there's something called Munchausen's, and it's a Count Munchausen, we believe, who, anyway, long story. But anyway, they used to go in, and this, they used to have, I think his wife or somebody would always have problems, and they thought she was making it up. Of course, in today's day and age, well, she's making it up and looking for attention, and they call it the Munchausen syndrome. And that's what medical students, nurses, they learn about and think, okay, well, this is one of the patients. And yet, you all know from personal experience, you're not seeking attention, you just want help. And so number one is you're not making it up, as you know, it's not in your head. And the whole thing can make you feel like you're crazy because you've been gaslighted. You've been gaslighted by professionals who should know a lot, telling you, well, the tests are negative, so you're fine. It's all in your head. And this is why I was late today, actually. An unfortunate patient had been through this for a long time, and it took me quite a while to get through that. You're fine, well. But at any rate, so number one, yes, you have an illness, and thank God we have a name for it, dysautonomia, and then it's connected to other illnesses such as the EDS complex, which is joint hypermobility, which comes from essentially the tissue that holds us together, collagen, being a little looser than it should be. So it's not just the joints that are flexible, but all the tubes in your body, even, going from your blood vessels to your gut, to any tube and tissue, which is made of collagen, is a little floppier. So, people will complain of having the legs swelling, and it's not just pipes in the legs which are floppy and letting the blood go down, but it's also the tissues are very spongy. So it's like filling up a sponge. So the legs are swollen. Gravity, gravity sucks all the fluid out. Other folks will come in with strange abdominal pains, and part of the reason is that the structures that hold the gut in place are also floppy, so the bowels can flip around and cause problems. In fact, the bowels themselves may not work well because of the dysautonomia, so it can be a terrible situation. Going further up with the heart, what's happening there is the control of system is not quite as good as it should be. And so, for example, the heart rate might go too low and then too fast. Instead of being reasonably variable, it is extremely variable. The same thing can happen when we're dealing with blood pressures, they can go from very low to very high. All this is from autonomic malfunction. And what we're trying to do here is to try and stabilize things. It tells me my internet is unstable. I hope I'm coming over. Any rate, so there's also other systems involved, such as the autoimmune system, which then of course affects the way you respond to infections, vaccines, etc. The endocrine system, which is all the glands, starting from the pituitary up in the brain, the thyroid, the adrenal glands, the pancreas. So, you'll see problems with all kinds of things like insulin, the blood sugars are going up and down, and it's like, oh, is it glycemia? Well, actually, it's probably dysautonomia causing the blood sugar swings. And I still haven't figured out exactly what to do, except my usual, which is to eat small meals and eat foods that are low in, have a low glycemic index. The other things that of course, the thyroid, we have a lot of our patients have thyroid issues, and they can actually often tell that their levels are off, and that's before the lab work shows anything. So sometimes it's okay to encourage patients to do a little adjustment to see how they feel. And then there's, of course, the system that deals with allergies. And so when your body sees something it deems to be an intruder, the mast cells, which contain histamine, they're activated and they will essentially come out in the bloodstream and start doing their thing, which is the defenses against an intruder. It can be as simple as hives or rashes, all the way to the throat closing up. If it's in the stomach, after you eat something that didn't agree with your health, the stomach gets bloated and it looks terrible, and it takes a while to go down. It can also cause diarrhea and so on. So there's this whole hodgepodge of symptoms coming from different places, and oddly enough, they're connected through both, the autonomic system, obviously, the endocrine systems are also intimately interconnected. So when I see patients, I'm trying to get to, number one, I try to do is to get the blood to the brain so that at least we have some of the autonomic controls maintained. And most of you have probably heard me telling you this, that first we try to do the natural stuff, it's simple. Water, electrolytes, salt, and then we add pressure to the system by having you wear compression to the lower body is enough. Other times we have to do more, and additional supplements I usually recommend are vitamin magnesium. It's a vitamin I suggest. It's a based vitamin called cardiamin, and of course education. So the plethora of sites you can visit. There's also a great little book I like, which is called the Dysautonomia. The key is not to get to a point where you're Googling everything, because that's going to drive you insane, because this is really a tricky subject. At any rate, the final thing that helps is, of course, knowing there are many, many people like you out there. And this is where the work that you all are doing this evening and from here on is so important, because it shows that this is not confined to a minority of patients. We know there's at least 6 million patients with dysautonomia, and that's before COVID. After COVID came along, COVID affects the autonomic system, and the estimate is about 20 million on top of the 6. So, unfortunately, there are a lot more patients now seeking attention because of this, which in a way has been a benefit to the folks like Carmen, April, and all of you who are here, who've suffered through slow diagnosis and eventually finding the right treatment. And so what we're trying to do here, I guess this evening, is to slow down the time it takes to get to a diagnosis. And every time October comes around, I'm telling all my patients, hey, be sure you look out for the turquoise superdome, because that's your sign, that's in your honor to show people that they need to get aware of this important condition which affects so many. And then, of course, the EDS group is also intimately connected with dysautonomia. A lot of the EDS patients have symptoms of dysautonomia and vice versa. So what we have here is a perfect combination of two very good awareness groups, getting it out there. And I always joke with my folks who have both. I say, you really need not just the turquoise, you need a zebra shirt with the turquoise stripes. So that would actually represent you very well. And I believe April has designed a shirt that even puts in the mast cell group, which, by the way, they're called the masties, and they have their own little support system. I think I'm kind of going on a little bit on tangents, and in terms of words of wisdom, I would suggest that be sure you stay hydrated, get your electrolytes, use whatever works for you. And you may have to try several to get to something that you tolerate, whether it be my mouth, like in a liquid form, in your water, or if it's a capsule or whatever. They have so many products out there. We're really blessed that there's so many different things you can do. If you can look at your medicines and learn how we are using them. We're not using them as they're described in the books always. So on the simplest level, I try to teach patients that what I'm trying to do with the blood pressure to control it is give you something medically, with prescription medicine, which can raise the pressure. But then we know that sometimes it's going to go real high. So I need to put the lid on that by having something that brings it down. So we're creating a sandwich. And fortunately, the one that brings the drugs that bring it down usually have a property of helping me control the heart rate, because normally the heart rates are also going wide band, low to high. So we can use a combination of a drug that raises pressure and one that lowers pressure to control the flow to the brain. And it also helps us control the heart rate. Now, in rare cases, we actually need a backup because sometimes the heart rates are too slow. So we actually have to add in a pacemaker because there's no drug that I can use to bring the heart rate up. So essentially, I describe it as we're like shrinking a big box where you're without help, your blood pressure and heart rate are bouncing around all over the place, and I'm squeezing them down into a manageable, smaller box, which in turn means that the flow of blood to the brain is more stable, brain can work more efficiently, and can control all the other systems better. So we're trying to reduce migraines, feeling of syncope or feeling like you're going to pass out, fatigue, mental fog, and so on. So these are all intricately involved, and oftentimes I see patients trying to get to deeper answers. I'm like, you know what? That's where I have to suggest, well, let me send you to some other specialists who can dig deeper to reassure you that there's nothing additional that we're missing. I always like that reassurance, and this is why I do some testing, which is simple, but it helps me know that I'm on the right path. Because the last thing I want to do is to miss something which should have been picked up by my testing, and I'm missing it. So it's always a fear in the back of my mind that I might miss something. So if you all wonder why I'm so slow, that's why. I'm looking out for you, because I couldn't go to sleep if I missed something because I was rushing. And so I apologize for being lengthy, but as you can see, I do enjoy taking care of everyone. And I see a lot to Carmen and April, or whoever is wanting to do the QAs, if we have any questions showing up, I'll be glad to take them. Thank you so much. Did you lose me?
Okay.
No, we got you.
Yeah, we've got you. Actually, as bizarre as it sounds, not one single person sent in a pre-question. I guess everyone was waiting for today. 2 years ago, you had actually released a video first and then saying that you would follow up with a Q&A. So they didn't really have that same my brain fog is kicking in.
The opportunity to go over everything and come up with questions.
I do have a question.
But the chat box is open if anybody would like to type something or raise their hand. Great.
Oh, okay. Can you hear me? This is Teresa. Or did
Yes.
I go back? Okay.
We got you.
So the one question I found, or I want to ask for the doctor is, do you find with the heart, it is mainly the managing of, yes, the blood flow to the brain, and then stabilizing the blood pressure? Like you said, sometimes it can be high, sometimes it can be low, sometimes you use a pacemaker. Are you finding any other conditions with the heart related to dysautonomia?
Okay, that's kind of like a great question. There's a lot of stuff in there. Really, the main things that we're seeing is truly the blood pressure dropping and the heart rate's not being controllable. But associated with it, we often see the venous pooling, and because dysautonomia and EDS are kind of interlinked, I look to see if there's venous insufficiency in the legs, meaning the vessels that are bringing the blood back up from your extremities in the legs, they have little valves, which are one-way valves, which prevent backflow. So as the blood is being squeezed by the muscles when you're walking upwards towards your heart, these valves prevent the blood from flowing back down. So we have to do that, and we do specific ultrasounds in the office looking for that. And just a word to the group that I often see this, that people have had these ultrasounds and they think they've checked. Most places, hospitals and so on, are just looking for blood clots. They're not really looking at a venous insufficiency. So sometimes, you'll see us reorder the test in the office specifically because the technicians know what we're looking for and we can fix this. Other things that seem to be connected with the vascular issues, on occasion that we'll see atrial septal defects, which are essentially a birth defect where there's a wall that goes up between the right side and the left side of the heart. And essentially you have two pumps side by side. And then when you're a baby, you have these holes. Usually it's between the upper chambers, which allows the blood to flow across so that oxygen can get to the baby's brain. Later, after the baby's born, that closes. And in most patients, sometimes we'll see it's open. Could be, it's called an atrial septal defect, and has various subclassifications. And sometimes it's bad enough to where it's causing migraines, worsening arrhythmias, and so on. So we can actually go in and close that. So that's another potential effect on the circulation.
Okay, let's back up just one more moment. You said you named something and it generates the migraines in arrhythmias. Yes. What was that term that you said?
Called an atrial septal defect, ASD. Okay. Yeah. And okay. Again, it has to be a fair size usually, but the research indicates that even tiny ones sometimes aggravate the migraines. And the theory is that there's maybe some microscopic particles that are going across from the right side of the heart to the left, and they're going up to the brain and going to tiny vessels and maybe causing some irritation, starting a migraine. We don't know. We're just kind of still kind of figuring it out. So often we'll recommend that kind of patient takes an aspirin, and that seems to help. But again, there's no research that will prove it.
Okay.
If they're really large, then we really do worry, because if they're very large, then sometimes clots can go across and cause stroke. So that is where we get to be more concerned, and we get more aggressive. And there are devices we can thread through a blood vessel in the groin usually up to the heart and close it like an umbrella.
Okay.
So that's the other thing you were asking about. Oh yeah. What else in the heart? Yes, long term, some patients have what we call inappropriate tachycardia, meaning the heart rates stay high, over 100 beats a minute. And when we do the monitor, they'll be doing this for half the time. I mean, the monitor can stay on for a week, and we're seeing the heart rate running at 50% above 100. Now that 100 is kind of a number thrown out there, but really it's telling me that it's going way too fast. And the simple way to look at that is, if you keep doing that for the rest of your life, you're going to wear your heart out. And indeed,
Right.
which is a lot of long words, is to say that if your heart goes too fast for too long, it wears out and you go into heart failure. And we don't want people to do that. So we make every attempt to slow down these super fast rates, which have been going on too long. Now, a lot of dysautonomia patients have fast heart rates, but they don't usually run this half the time at over 100. They may be like 10% over or 5% over. So they're not of that great a concern, but we do try to slow them down, and it allows the blood flows to be more stable. So that was another potential thing with the heart. Oddly enough, what we're seeing is dysautonomia patients are not dying of heart attacks. They all worry because most patients, when their system is going whatever, there's discomfort in the chest. It can unstable internet again. I'm sorry. Okay, here you go. All right. So it was the blood pressure, chest pressure, chest pain, and it may even go up into the arm, the left arm, the neck. It's just exactly what you read. That would be a heart attack. And yet when the doctors go in and check, there's nothing. And that sensation caused, sorry, it's not attack. It's usually from the autonomic system overreacting to something else going on. On occasion, it can be due to spasms in the tiny vessels that feed the heart cells. And so sometimes we can treat that with medication. But a lot of the times it's just treating the basic dysautonomia that helps everybody feel better. And of course, a lot of reassurance, knowing that you're being checked and you're not having a heart attack. So hopefully that answers a little bit of your question.
Yeah, it definitely did. That really put a lot of light on it. So that was very helpful. Thank you.
Someone in the chat kind of
You're welcome.
piggybacks on all of this and asked that if you've been diagnosed with POTS, should you get regular cardio checkups, or is that unnecessary if you're having stability with your symptoms and you've been able to follow all these recommendations? This is somebody not with EDS, but just with POTS. Do they still need to come have for their cardio checks?
You know, that's a great question again, and it varies so much from individual to individual. What I see is that there are some folks who, once we've educated them, they kind of essentially graduate from my little university, as I like to call it. Usually within a year or so, they're kind of comfortable, and then I'm letting them adjust medicine. They got it. They got it, and they say, you know what? I think I can handle this. And they may not come back for a year or two, and that's fine. If there's anything physical that we've detected, thing that needed to be checked again, then yes, we do want you to come back. For example, one of the commonest findings in the heart sphere is a lot of patients with the with dysautonomia and actually EDS to have slight mitral valve leaflet. The mitral valve leaflets are essentially tissue which is flapping up and down, and when it comes up, it closes. And I'll show you that. It closes like that. And that's normal, but in a patient with dysautonomia and EDS, they can be a little more elongated and they'll actually come up this way. That's a full prolapse. When it does that, blood can backwash into the lungs, and that can cause other problems downstream, like high blood pressure in the lungs, which is called pulmonary hypertension, and then it causes heart failure and so on. So it's rare, very rare to be that severe, but we do have a couple of cases where we've had to do something about it. The majority of patients with this may have a little bowing when they go up like that, just not a prolapse, but it's just a little bowing that, okay, you're the variant, which is benign. But over the decades, when physicians first started doing echoes, they saw this and they said, oh, look, you got this, you've got palpitations, chest pain, so you have mitral valve prolapse syndrome. That syndrome exists, but it's actually part of dysautonomia. The dysautonomia is kind of a big old umbrella, and it covers these subsections. And the EDS folks may want to know that their collagen is a little stretchy, and that's why the valve leaflets stretch. So I see these associations. We actually need somebody at NIH to do some research on a big population basis. But these are just simple observations over the years.
Okay.
What were you asking? I forgot what it was. Oh, the follow-up, especially like the ones I was talking about, the tachycardia, where the heart rates are very fast. You don't want to be going thinking, feel fine, so I must be okay. If we detected that, you want to check in a year or so. Oh, we're still good. Does the medication need adjustment, or can I come off, or whatever? Some of the worst things that we've seen is when the patient feels well, they go for a while and then they'll start weaning off without thinking. And then when they have a big decompensation, we end up having to spend a lot of energy and time trying to get them back to where they were. But it's, again, those are rare, thankfully rare, which is why for the majority of our patients, we're able to let them manipulate medication. And I call it, actually, that leads to an interesting thing, that dysautonomics and EDS patients often have unusual reactions to medicines, or they're very sensitive. And so you cannot just go by the textbook of, okay, this is a low dose and this is a high dose. We actually have to make an allowance, because the way the cells work in some dysautonomia or EDS patients is different in terms of processing. So when we give a drug at the quote normal dose, it's too much. It overwhelms the cell's ability to process. And so by the time the next few doses come, we get into toxic range. So what I try to do is to educate patients to start everything at a low dose, low and slow. You can always put more in, right? You can't take it out as quickly. And if possible, avoid injections at full strength. Ask, beg with your doctor, hey, can I have a little bit less, maybe a half or a quarter? And the whole concept being that if you're putting something in the body and it doesn't like it, if you put a lot of it, you're really not going to feel good. And that seems to work well for a lot of patients in going low and slow. Which also brings me on to another thing about steroids. And you'll notice that steroids are used in about every branch of medicine. Everybody has, oh, you have a problem here, let's do a steroid. It's kind of like the modern snake oil, because it actually works temporarily. However, it can have lingering effects on the whole body. And some of those effects include unexpected weight gain, your blood sugars being out of control, getting irritable, angry, moody, depressed. Tissues can become more fragile in some cases. So one always has to be a little careful and use less rather than more, unless it's a true, life-threatening problem where we do use high doses of steroids. So that it's just another kind of sideline to everything in small amounts and then increase it and do it in moderation, because when you have dysautonomia, it's kind of tricky. I'm seeing a couple of questions on the oh wow, on the chat. Let me see if I
Yes,
can
we have a
answer
lot of
those.
questions coming in, and we have a few hands raised. I'll read one
Oh.
question off of the chat, and
my-
then maybe we can go to some of the people who have raised their hands. Somebody, since you were talking about the effects of everything, someone had a question: how does anemia or high ferritin levels
Okay.
affect the heart in dysautonomia?
Okay, that's again, I'll be honest, I've learned a lot in the last couple of years since we last did this because of the volume of people. And so I began checking to see if they were lacking in, iron stores. And lo and behold, the red cell count, which is the number of red cells floating around the bloodstream, might be normal. But if you do the deeper test, which is looking at iron stores and ferritin levels, when they're low and you correct them by giving iron, patients seem to do better. They feel better, a little more energy. And I don't know if this is because there's an absorption problem but it certainly to give them supplemental iron. As far as the heart goes, it's actually the other way. If you have excessive amounts of iron, it can deposit in all your tissues. It's a condition called hemochromatosis. And of course, there's a support group for that if you get iron from the tissues. Because for example, if it's left in the liver, it'll cause cirrhosis. If it's left in the heart, then it can cause heart failure. So yes, these things can affect, besides just the blood, excessive iron can also affect other tissues. Was there another part to that? That was the main question.
It was saying anemia and high ferritin levels affect the heart in dysautonomia. Okay,
yeah,
we have Carmen, then Stephanie, and then Jenny. I'm sorry, did you want to add something? Go ahead. Did you have something else to add, Dr. Patel?
No, I'm good. I was just, my neck's getting a crick, so I'm gonna elevate my desk. Let me know if you lose me. I'm just rising with my desk.
All right,
I have this fancy, yeah, it just, if you don't, I went too far.
We see
Okay,
you.
yeah,
Carmen, you had a couple of
look at this
questions.
camera. You don't see me.
We see you, great. We'll do Carmen, then Stephanie, then Jenny. Go ahead, Carmen.
Hey, Doctor, I was turning my mute back on or off. Dr. Patel, can you explain coat hanger pain and why people with dysautonomia have such chronic pain in the neck and shoulders, and specifically coming around that left side? That seems to be very common, and I get that question quite often, and I don't know exactly how to answer that for people, and I suffer with it. That's my biggest number one everyday issue. So maybe you can enlighten us.
That's a great question again, and it's kind of like I'm guessing this. I'm looking for something that'll tell me this is what it is. One thing I'm thinking is that in dysautonomia population, when by the blood not reaching the brain, it's not just the brain; it's actually even the spinal cord, because it has to get up, and then the spinal arteries go down. And you can imagine trying to pump stuff up and the pressure is not good enough. So I believe some of that is from the nerves, not the nerves, sorry, the blood vessels to your spine, not being able to get enough blood into all these areas. But there may also be other reasons, which may involve the neck. And it's interesting that and I see exactly what you're saying. Most of it's left-sided, and there's an autonomic chain that runs up and down on that left side of the body. So I'm wondering if it's because that somewhere along the line, that chain is being disturbed or being pressed on. Maybe there's bone spurs, because we all get them as we get older. That may be triggering some reflex pains. But it is extremely common, and it's also in the back of the neck, and it's to do with posture partially. Sometimes wearing those special shirts they have to improve posture helps. And of course, on occasion, I've seen where it's from something called craniocervical instability, where the bones of the neck, especially the ones right there, which are holding up your whole skull, those joints there, and you can imagine your head's moving around a lot. That's 10 to 15 pounds of weight. And the muscles, the strap muscles that keep us looking straight ahead, they have to do a lot of work. The best thing is to be looking straight ahead all the time. Well, most of us nowadays are actually looking down at our phones or computers, laptops. So that's part of the problem too, I think, is the fatigue of those strap muscles which hold the head up. I think you'll be talking to Dr. Cram, or he'll be talking to you all, and he does some important work there to help with some of those signals from the autonomic system and the spine. Now, he's the expert on that, so I'm going to defer to him. But it's kind of one of those tricky ones where there's no good answer. And I think exercise, whatever exercise you're able to do helps. Something to help strengthen those areas. And it is just so very interesting that just like you've observed, most of the patients have left-sided symptoms. We even have patients, as an aside, who have migraines, and they are called stroke migraines because whatever's happening in the brain is significant to where the body essentially on the one side stops working, and it looks like a migraine. Everything's not looks like a stroke rather. And when the hospital does all the checking and testing, there's no stroke, and they recover just fine. And again, it's on the left side. So this is why I believe it's something to do with the autonomic chains going, which are mainly on that side. There are physicians who do things called stellate ganglion blocks, and sometimes they're effective with these pains, but they're tricky. Usually it's an interventional pain management doctor who can do those, and they go in and block the stellate ganglion, which is one of the major autonomic ganglia that are residing up here. Anything else on that? I wish I could add more, but I'll be honest. Perhaps occasionally getting a gentle chiropractic treatment or massage may help. Acupuncture, dry needling, those kind of things may help. But they're temporary. That's the problem. You have to keep going back because things get out of alignment. I hope that answered some of the mystery.
Stephanie Lambert, your hand's been up for quite some time. We'd love to hear your question.
My question is how to restabilize when you're pregnant, especially when medications have been taken away, and then you catch a virus that has you down for a week and a half, and trying to get your body somewhat on track that was already no longer on track, and then is pushed even further off track by illness.
Yes, that's that situation we come across quite a bit, and it's very tricky because as you all know, with autonomic disturbances, even the weather change can put you down, let alone an infection. And then pregnancy it can go either way. Some ladies actually feel better because the higher blood volume and perhaps some of the hormones changes that occur. Others it's not that good. So if you have an intercurrent illness, it's usually, hydration, rest, give your autonomics a chance to recuperate. If you're pregnant, sometimes I've seen that, doctors, the OBGYNs, high risk OBGYNs, they get very panicky about medication and they want to stop everything. It's like, hold on, you don't need to actually stop everything. You should stop mostly everything, but there's a couple of things that the patient can still take depending on which stage of the pregnancy they are. So oftentimes simply the fluids, electrolytes, compression, I mean, obviously those are okay, continue that. But as we get along, we have to also worry about the baby. So usually beta blockers, they can be used. However, we are watching the growth of the baby. If it's any sign of the growth rate slowing down, then the beta blockers may need to be removed and use a different medication. Now, again, sometimes physicians are just reluctant to add any medication because there's very little research on what is safe and what isn't. So we do use something called calcium channel blockers, which can help with heart rate control. Generally, the bed rest and all that helps, but it's very tricky for pregnant women because it's kind of a situation brought on by the fear of giving a drug and causing harm to either the baby or the mother. And way back many decades ago, there was the infamous drug called thalidomide, which was given to women, I think in Germany, in Europe. And unfortunately, it caused lots of birth defects. And after that, manufacturers, the regulatory folks, all got very scared of doing any kind of trial work on pregnant. Almost like, well, we look it up, we try to figure out what we can use and what we can't. For example, there's things like fludrocortisone, which is a mineral corticosteroid. It's not the same as prednisone, but it's a cousin, but it has a different effect. We often use that during regular, for regular dysautonomics, but when they get pregnant, we take you off of that. And that is really important because it can definitely affect the way the pregnancy goes. There's a drug that we sometimes use that's called midodrine, which helps elevate the pressure. And there's very little research on it. But having dealt with several patients who nothing was working, and with this is a good discussion, we tried these drugs, and lo and behold, they did better. They didn't fall over from passing out while pregnant and harming the child or themselves, and there was no defect. So, I've kind of had to just sit with patients and on a one-by-one basis to see what to do. The same kind of principle applies to breastfeeding after pregnancy. We've got to be very careful that we don't give a medication that goes through the milk to the baby. So we try to restrict medication as much as possible, but sometimes we need something, and there's several drugs that we can use which are safe. During pregnancy, one thing that can help if we can't use a drug for pressure support is intravenous infusions of fluid, which is also tricky because sometimes, there can be excessive weight gain just from the fluid. So in general, this is a very difficult situation. If you're a dysautonomic lady who's pregnant, it can be very difficult. And then if you get sick on top of that, it is really, it's put you out, and it can take you a lot longer to recover because your autonomic system has had to deal with too much pregnancy and the intercurrent illness. Unfortunately, a lot of this it takes time. We have several patients who initially weren't doing that well, but over a period of 3 or 4 years, they've done remarkably well and stabilized. So you gotta kind of hang in there. That's my best advice on that.
Thanks.
Okay, did that answer all your questions, Stephanie?
Yes.
All right. I think Jenny has her hand up, Dr. Patel. Jenny, would you like to pose your question?
Hi, Dr. Patel. Thank you for your time. I don't mind saying publicly, it's fine. I have the trifecta, so EDS, POTS, mast cell, yay me. And additionally, I have a diagnosis of Malday-Debartment syndrome. So I was wondering if you could speak to what you've seen in your patients as far as dysautonomia affecting the vestibular or balance system.
Yes, that's another very common issue. Of course, many dysautonomics are dizzy and they will go the route of the ear, nose, throat doctor, and then they'll go to the neurologist and have testing, MRIs, etc. And ultimately, the balance organ sitting inside our ear, in the ear canals, near the ear canals, it is integrally connected to the autonomic system. So, for example, if the autonomic system is under stress, then what can happen is that the patient will feel nauseated, and that's actually a red flag saying, "Uh-oh, the autonomic's under stress." And once you correct whatever that needs to be done, is it hydration, whatever, the nausea gets better. If you give a nausea medication, of course, it helps the nausea, but it also, a lot of them help the balance organs. So they also work by directly interfering with the signals from the balance organs, which are causing the nausea. A lot of dysautonomics find it difficult to travel, even in a vehicle, because of the moving around of the head. It can disturb the balance organs. So by the end of the trip, they're throwing up or like just no good to anybody. Giving medication ahead of time can help. Anything from like Zofran or prochlorperazine, using the little patches behind the scopolamine patches. All these things are good preventatives. And with the other thing that we've seen with the balance organs is there's things like the canal. There's three canals. One is like horizontal, one is going straight up, and the other one's in the back. So it's a three-dimensional system inside the ear. And inside these canals can sometimes have problems with leakage of the fluid that's in there. And it takes some specialized testing and surgery to fix it. And everybody could go, patients go in, have these done, and sometimes it works, but often, unfortunately, the leakage and everything is not the primary issue, and the disturbance continues. So we are fortunate to have a world-class doctor who actually is in Covington, right there, Dr. Giannoli, who does that. But it's like very tricky. I see some of those patients, and we try to work on their autonomic issues as well. Sometimes working on the inner ear and fixing those things does help, and sometimes it doesn't. It's a tricky situation, put it mildly. What else can I tell you about that?
I think you covered it very well. My neurologist is starting me on IVIG, so we're going to try that. And I have done vestibular therapy, which was somewhat successful, but kind of plateaued and didn't get any further. So hopefully coupling those will give me some relief.
Now that you mentioned IVIG therapy, I just realized something I forgot to mention is I don't have access to that in my practice, but sometimes we can get that through neurology, immunology, rheumatology. It's very difficult to get it authorized because it's an expensive therapy, but it works on the immune system. And we see patients who are on the therapies, the dysautonomia seems to improve. In the majority of cases, it improves. So maybe down the road, when they do more research, this might become one of the treatments for dysautonomia patients. At this time, though, it's not going to happen anytime soon because they have to do a lot of research trials just to make sure that would be appropriate. but that's just a personal observation that the majority of the patients who go on these IVIG infusions or similar things, a lot of the folks with the mast cell syndrome, they'll receive Xolair, which is not as powerful, but it works well. And we see a lot of the autonomic symptoms also calm down. So it's a very interesting kind of connection between.
Okay, we have some more questions.
Yeah, go ahead.
Oh, I'm sorry. My computer's lagging, so I thought you would stop talking. Go ahead, finish.
No, I was done. I said, okay.
I was going to say we have a few more questions on the chat, but I did have one question to kind of follow up on that. Is there anything on the horizon right now, Dr. Patel, that is very promising to help people with dysautonomia? Is there something we just have to hang on for a little bit longer for clearance?
Yeah, unfortunately, I wish I could have brought you a gem and said, yay. It's not there. The main thing we're seeing is that because of COVID-induced dysautonomia, there's a big push now for organizations to, in national level to get in and say, we need to do some research because we're going to have a population of 20 million people who are otherwise healthy and now unable to work. So there are a lot of economic factors driving the need for research. And I haven't come across something right now that I can tell you all that, okay, you know what, that looks so promising, we'll be diving into it. But I keep reading and trying to educate myself as best as I can. And look, if patients come to me with some treatment plan which is promising, I'll look at it. But like I said, I wish I could give you better news, but I don't have.
Thank you for trying to stay on top of the latest and greatest. I know this might be a little out of your field of cardiology, but somebody had a question saying, what can be done to help minimize gastrointestinal problems, such as severe diarrhea, when medications do not work? Blood work shows nutrients are absorbed and stool tests do not indicate any problems.
Okay, so that is actually potentially it could be an autonomic issue where, again, the autonomic system can cause issues with absorption of nutrients, and it can go both ways. Sometimes it causes us to retain more than we need, and you may not be eating much, but you're gaining weight, and you're like, where's it coming from? Or it could go the other way, and nutrients can go down. Now, the diarrhea and constipation, you can alternate, or some folks, unfortunately, have mostly one or the other. And the diarrhea, which obviously the GI guys have checked everything, infectious disease, etc., there's nothing going on that they can fix. Sometimes it's simply we have to do palliative treatment for that. And that includes using, from my field, we use a drug called cholesterol. It's cholestyramine, which is a very old drug which binds cholesterol, but has a property of binding the bile acids in the bowel, which help reduce the diarrhea as well as the burning it causes and the irritation. The newer drug comes as a pill and it's called Coliselvum or Welchol, and that also works to an extent. The over-the-counter Imodium can help, but sometimes it doesn't. There's a prescription version called Lomotil, an old and trusted one, which is a restricted, for unfortunate patient who's having diarrhea and having to carry change of clothes and diapers. It's a godsend, and you can get your errand done and you don't have to worry. So that's available. I've seen some other physicians, I've never come across myself, but they've given tincture of opium. I said, wow, that would obviously, opioids constipate a patient, so it helps cut down diarrhea. So there's various things. If the physician can kind of, look further apart from just say, okay, well, this is all we can do. Sometimes we can help with that. A lot of this diarrhea is, I'm not sure what it is. you sometimes have to do elimination diets. You may have to look at, are you doing a lot of artificial sweeteners, which may cause diarrhea? Some folks are taking things called PPIs, proton pump inhibitor, which is like for acid reduction. Well, some of them can cause diarrhea. Cutting down the dose of that can help. Some folks with mast cell activation syndrome, the diarrhea is actually an allergic response to whatever's going on, and getting on the right medications for the mast cells. Usually, I'll say, look, while you get in to see the doctor who specializes in this, you can try over-the-counter Zysol, which is like these Zyrtec, but the more advanced version, together with Pepcid, over-the-counter Pepcid. So, sometimes they can try that 2 or 3 times a day until they get in to the allergy immunology specialist who can diagnose whether they have this condition, the mast cell activation. Some of the gastro doctors are now, I saw, seeing that they're actually looking for mast cells when they do their biopsies. So that's good news, we could take a biopsy looking for mast cells. And this is important to this group as well, because a lot of patients have minor symptoms of the trifecta. The trifecta, for those who may not be familiar, is you can have dysautonomia, EDS, and mast cell activation. That's the 3 main ones. And a lot of folks have a little of everything and a lot of one. So you might have a lot of dysautonomia symptoms and maybe a little bit of mast cell, maybe some joint hypermobility, but on the very low end, where they look at the Beighton scale and say, well, you don't have it, but actually you have the variant, which is very mild. But each individual is different. And sometimes you just have to think out of the box. And this is what I try to do. And it's really just getting the patient's confidence to let them know that, look, I'm looking out for you, trying to help you. So it's a journey, and it's trial and error. It's not always written in the book of medicine what you're supposed to do. But these are things that have helped. So hopefully that'll help somebody on the group with the diarrhea issues.
Thank you. Well, we know you're well versed in all this, but not all the doctors are. And you're one doctor trying to serve all of Louisiana, which is so hard. And sometimes, the people do have to go to a cardio that's not well versed in dysautonomia or EDS. So there's a question from a member asking, what diagnostic tests would you recommend getting as a baseline workup? You spoke about how important it is to have all that information, that data, and put the whole picture together. What would you recommend if they're having to go to someone who doesn't know like you do?
Right. Yeah, that's a great question. Actually, the most important one is listening. But in the busy world of medicine now, very few people will take the time to sit and listen, because really the great doctors of the past, it was actually saying that Sir William Osler said that when you listen to the patient gives you the diagnosis, and that's it. That's what I've seen in my entire career. All this fancy testing only confirms what I'm thinking, but most of it is done in the conversation, the symptoms and so on. I have a little sheet with all these peculiar conditions and things, and they connect. Sometimes a doctor will listen, but mostly you don't want to be going off on too many tangents. Doctors think in systems. So, when you walk in, they'll give you a sheet with a review of systems. So they start maybe with the brain. Are you having migraines, dizziness, etc.? Then they go down to breathing, then chest pain. So that all these questions they're asking is that they're getting an idea, what are your main symptoms? Not to confuse your doctor when you go in, you want to give them the main one, because most people, of course, have almost all of them checked off. But we need to focus on some primary ones so we can get those out of the way, and then the rest will generally get better, but we can work on them later. Testing wise, it's very simple to just lay the patient down, do a blood pressure and heart rate, and then stand up. And it's like the poor man's pill table. It's like every doctor has their own little way of doing it. The stuff you read in the books with all the machines is the research protocols. And if you listen to Dr. Satish Raj, who's one of the leading research doctors for dysautonomia, he says, you know what, guys, all these numbers we put in there, like, okay, your heart rate must change by 30 points, or your blood pressure drops by X numbers. These were put in just, we were guessing, and we needed something for research. So we said, let's do the cutoffs. And this is so important to understand in medicine. A lot of the numbers that you're being presented with are simply numbers to help us put you in categories, but a living, breathing human doesn't belong in a box. You're always a little continuum of that number. Back to the tilt table, though, ask them to do that. That's really, and then of course, all my nurses on this Zoom will have to forgive me, but you're all taught you got to lay patients down and sit them for 3 minutes and then stand them. Don't do that. For dysautonomics, it's easy. It's just laying and standing. And the reason is that if they have significant dysautonomia, they decompensate so fast, you don't need a tilt table test. You can tell. It will save that patient an awful test. I used to do them, and then I saw the problems that cause the decompensations. I said, you know what, this is nonsense. I know what's wrong. Let me not put them through this unless they really need it for some reason. So we kind of do them in a gentle fashion. But certainly a poor man's tilt is great to make sure they're not missing an obvious rhythm problem. An echo of the heart shows the chambers. In my clinic, we tend to do a bubble study on all the new patients to ensure that there is no atrial septal defect as part of the equation. Some doctors won't want to do that, but that's up to them. Depending on the age and the stability of the patient, we usually do a stress test. And I'm looking at how the heart rate responds to when they're walking on a treadmill and how quickly they wear out. That gives me an idea of how does this affect them? You get tired within 3 minutes, you're like, oh my goodness, you really are not able to hold up. And that we have normalized table telling us how to compare different patients. The other part of the stress test is looking for blockages. So we see some changes on the EKG, which tell us if we suspect any blockage in the arteries of the heart. Depending on doing this stress test with an echo, which is a sonogram, or with a nuclear scan. And depending on the age group, I may order a calcium scan, a coronary calcium scan, which tells me if they're developing significant calcium in the arteries of the heart. Sometimes all the other things can be normal, and yet that one test is like, oh, we need to look a little deeper. A 7-day monitor is ideal if you think it's going to be very cumbersome after the first few days. So I'm grateful for whatever we get, but a monitor helps. And again, the issue there is that patients are told, oh, you're fine, your monitor's good. And when I said, no, you're not. The heart rate's ranging way too much, and there's way too much tachycardia, meaning the heart rate's too fast. And it's missed because of the type of monitor that's being used, or the processor that they're using. So I often repeat them, and I'm like, lo and behold, this is what it was. So a good monitor helps. These are like very basic things, which I think most cardiology practices would do, or even your regular doctor can order and give you a baseline. So we're talking about EKG, echo, stress test, and a monitor. Those are kind of basics. Beyond that, we get into more specialized stuff, such as autonomic testing of the autonomic system, which is done in big centers. They do something called pseudomotor testing, where they check the sweat glands and how they respond, the responses there. Some centers have machines that can measure how your blood volume changes as things go on. And yeah, there's many different ways of looking at this thing, depending on the availability of equipment and personnel and finances. Some of the doctors will go a little further, and this is more specialized doctors, like they may do what they call a small nerve fiber biopsy, see if you're having a neuropathy of the one part of the autonomic nervous system, which is causing the problems, which can help in some patients guide their treatment. Those are kind of like the basic ones. I don't think we have a pretty good idea of what's going on, and then we can work with those and go further from there. Oh yeah, one other test that I do in my practice quite a lot is venous Doppler. There's an ultrasound of it looking at the abdominal aorta with an ultrasound in case there's some weakening or dilation of that vessel because of the weakness of the collagen, which is in the big vessels of the heart, as well of the heart. So the body going up to the heart. And especially if there's a family history of aneurysms, we always kind of wonder, okay, is this somewhere else that we are seeing this problem? So we will check it with ultrasound or advanced imaging, CAT scans, MRIs, and whatever. So there's a couple of things we can do. Oh, of course, I forgot one important thing, the lab work. And as you all probably know, I do quite a bit. I'm doing the basic blood count, metabolic panel, magnesium level, thyroid profile. We do a lipid profile, do the iron studies, we do vitamins, the vitamin D, which is often very low in most of the population we treat and needs to be treated. We do vitamin B12 and folic acid. Those are kind of like things I do routinely. I'll also routinely do a urine analysis to make sure there's nothing else going on in that department. I'm not comfortable in doing hormonal tests, so I usually send the patient to the gynecologist if it's a lady, or a urologist if they want detailed testing of their hormones. So that's kind of about covers everything I would normally do.
Do you also recommend a sleep study usually, Dr. Patel?
Yes, thank you for reminding me. Okay, so the reason that we do that is if we suspect sleep disordered breathing, which can be manifested by snoring or simply stopping breathing temporarily while you're asleep. And by the way, those things are getting commoner now because of the obesity epidemic. As patients are gaining weight, there's more tissue deposition in the throat area, and it causes narrowing. And if your relative is snoring like a train, it's going to be terrible. That's a potential risk factor for heart attack, stroke, and it needs to be addressed. So I usually order a home sleep study, which is a lot more comfortable than the old-fashioned go to the lab and sleep in an uncomfortable bed with somebody watching you. That doesn't work well. So the home sleep studies work much better, and that tells us at least which direction to proceed, whether we should refer you over to a specialist or not. Sleep studies are particularly important for EDS patients because, again, the collagen tissues are weaker than normal and the airways can collapse, even in thin people. And sometimes I see young folks very thin and they can't believe they have sleep apnea, and they really need treatment, and they eventually get it and they feel better. But yeah, just because you're slim doesn't mean you don't have it, especially if you have EDS. So the only way you know what's there is if you look for it. So seek and you will find.
Thank you. We have just about 13 minutes before 9 o'clock. We have a few more questions on our chat, if you don't mind, Dr. Patel. Someone asked, can high proteinuria be connected with dysautonomia, and how?
The proteinuria, usually I will refer them out to the nephrologist, who will check to see if they are having something called nephrotic syndrome, or is it due to a kidney disease, meaning the tissues in the kidneys themselves. Yeah, I keep wondering myself about this, so I do check it, or on my routine urine tests, I check for protein. I haven't seen any trends. So from my experience, I'm not seeing that, okay, dysautonomia means you're going to have proteinuria. But I always wonder, if you're an EDS patient, would you be more likely to leak protein? But I've not seen it. So, so far I've not seen it, and I've not seen any research on it. So this would be one which may be more to do with kidney disease itself. And because we know that this whole thing can be autoimmune, there are certain autoimmune diseases that affect the kidney. And the kidney specialists usually are pretty good about checking all those to make sure there's not an autoimmune component involved. If you happen to have other symptoms of autoimmune diseases, joint pains or things like that, or you have the Sjögren syndrome with the dry eyes, dry mucosa, you kind of make a case for, okay, look deeper, and maybe there's some source beyond the kidney that is actually affecting the whole body. And then the kidney's proteinuria is actually just a symptom. Just like patients come to us and they have migraine or they're passing out, but it's actually, it's a bigger than just one thing. You have to look at the entire body. I hope that helps a little bit.
Okay, we have another question. If we have been diagnosed with a blood sugar condition like hypoglycemia without diabetes, but it only affects us sometimes, could it just be dysautonomia?
Again, this is an observation that I've seen. The more and more I see patients who have this, quote, hypoglycemia, I believe it's actually related to the autonomic system, because what happens is when you have a hyperactive a hyper alert autonomic system, if your system is sensing that there's some kind of stressor, it hits the gas essentially and causes release of various hormones, which will actually release a lot of glucose initially, but that can deplete really quick, and then the blood sugar can dive. And you may miss the high sugar because you don't feel bad, but when the sugar falls, you feel bad. So I think there's some connection. I don't know exactly what it is, but I have several patients who've been told they have hypoglycemia, and I'm looking at the circumstance. I'm like, you know what? I think this is more dysautonomia, and try just eating your meals more frequently, so you're not getting a big load all at once in your stomach, and also use foods that are low glycemic index. Simply means that they don't release sugar as fast. For example, if you drink apple juice, you're going to hit your stomach with a ton of sugar all at once. That's a high glycemic index. Whereas if you actually eat an apple, that's a great thing. It's a slow releasing sugar, so that's safer. So if you want to know more about that, it's all over the internet. You can look up glycemic index of foods. So try to eat the ones with a lower glycemic index.
Okay. Somebody was asking, do most medication side effects for dysautonomia, arrhythmias, and heart rate issues go away after a while? This person wants to quit their medication already because the nausea and heartburn are just too much for her. And they want to know how long, I guess, it'll take. It will go away after a while.
It's a very tricky one, and it's an individual thing, but usually we don't want patients to suffer unnecessarily. If something's not working, well, harking back to what I was talking about before, you always got to start ultra low, and low is different for each individual. when I give out a low dose of something, it may be perfectly okay for 80% of the patients, but the other 20%, it may just not be low enough. And this is why I just give everybody low therapy and go up. But even that low therapy, like a half a pill, can be too much for that individual. So that's where we go to the micro treatments and go down all the way to a little powder and work your way up. Now, if you still feel bad going up on that and you say, okay, I've tried the powder, the little crumbs and the quarter pill or whatever, then it's probably not a good idea to keep pushing it. Sometimes we have this feeling that if I just did more, I'll be better. Probably not. If you're actually feeling worse, it's time to wean back down. And this is best done in conjunction with the doctor's advice because, individual cases are different. And we sometimes see this, it's patients just can't tolerate a plethora of medications. And we have to just say, okay, well, let's not keep pushing stuff. Let's look further of some alternative way of handling the problem. So check with the doctor before. One quick word on this. Do not stop things abruptly if you can avoid it. As you go up on your medication dose, you should walk down the same steps so that you don't shock your system, especially for things that affect like we use to calm the system, like SSRIs, like Lexapro, or any of these drugs which at high doses were used for depression, but at tiny doses they calm the system. That or the benzodiazepines, which we sometimes use at low doses. If you suddenly stop these, or even if you think, oh, I'm weaning over 2 weeks, it's too fast. It's got to be a much gentler curve. And we've had some of the worst decompensations in our dysautonomics from other doctors deciding, well, the DEA decided that this person doesn't need to have this anymore, so we're just going to got one month or 1 week to stop, and that's not a good idea. So it's very tricky for patients, especially with restricted substances, when the physicians don't understand that the wrong way once it's too fast. But hopefully that can help you a little bit there.
Okay. We just have a couple more questions. We're going to ask that we cut off any more questions put in chat, just because we do want to get in the ones that have been submitted already, and it's getting late. Is there any connection between dysautonomia and epilepsy, in particular the rare form of focal reflex epilepsy?
It's an interesting one. We have several patients who, a neurologist in town who's very much aware of dysautonomia had sent over, and he said, they don't really look like epilepsy, but they're being treated with drugs, etc. And sure enough, they actually had autonomic dysfunction. Drop in the blood pressure was triggering whatever center in the brain that was irritated into throwing up seizures. And having controlled the dysautonomia, the anti-epilepsy drugs could be gradually weaned off. And, so it always makes me wonder how many patients are walking around with the diagnosis of epilepsy when they're actually having dysautonomia problems. And sometimes this occurs in childhood. So, they get put on medicines ever since they're little kids. But we're able to look at them and gently fix problems. And again, never stop epilepsy drugs, but you want to go, in conjunction with neurology, make sure that you're doing the right thing. So I don't usually stop the drugs. I'll ask my colleagues in neurology, can you perhaps try that? And if they're receptive to the idea of autonomic dysfunction, then they're glad to oblige. Otherwise, you have a problem. So I don't know if that answered the question completely, but hopefully it did a little bit.
Okay, thank you. We had a question about how do we know what level or kind of compression garment to get and where to get it from?
Okay, so that's compression is The books will say, oh, you need a maximum compression, 30, 40 millimeters. Well, if you ever try to put on a pair of compression socks or anything at that strength, you need physical strength. And if you have EDS and dysautonomia, you're out of luck. You can dislocate every joint trying to pull those things up. So what I've usually recommend is, look, do what you can. Even gentle compression works. You layer it. So for example, especially for ladies, you can wear pantyhose, which has a little bit of compression all the way up. That gives you a smooth surface. You can actually pull on slightly tighter compression, maybe a 10 millimeter, and it doesn't have to go all the way to the waist. Even if you get it up to the thigh or your knees, it's better than nothing. And so when you layer, you're actually able to do better compression. And also remember, if you're standing or sitting, the maximum compression is needed further down. So if you can get more compression onto your feet and calf muscles, that's okay. And the rest can still be compressed. Research does indicate that we need compression on the thighs as well. But one has to kind of look at practicality. For EDS patients, if we were to have you try to put on high compression all the way up to the waist every day, you're going to dislocate wrists and shoulders and God knows what. So layering is a good idea. And it doesn't have to be medical grade. Having learned from the patients, they'll come in with ideas. So I usually give out my little list of sites. And one of them that the ladies love is Crazy Compression. I guess that has some decent patterns or whatever. So they don't even look like compression. Leggings seem to work well. Spandex works well. Biking shorts or similar works well. So there's a variety of different kinds of things you can do. And of course, if you're living in the South, like here, in the summer, it's almost impossible to wear anything. So, it's kind of you got to see what you can do. My suggestion to folks when they're traveling is wear your compression in the car, like have something that's easy to put on and off in the vehicle. And when you get out, if you just can't tolerate it, you can at least take it off. But when you're sitting in the car, you're not squeezing the calf muscles, which pump blood back to your brain. So that's why when you get out of the car, you might just pass out right there on the curb, because here you've been sitting for a while, and then when you get out, blood is rushing down to your feet. And sometimes accidents have occurred to patients who are driving because they get woozy or dizzy and lose control because they're not wearing compression. So this is why it's important, if you're going to be using machinery or whatever, to do that. A very common occurrence I see in patients is standing at the sink or doing something stationary, standing, not wearing compression, not moving. So try to move around all the time, because that activates the pumps in your legs. And if you can't, the compression helps. The websites are all over on Google, but there's something called compressionsale.com, I think was another one. There's surgicals. I can't remember them off the top of my head, but there's a bunch of them out there. But it's what works for the patient. Now, if all else fails and you need a prescription compression garment, that can be written and it can be taken to the local medical supply store. But they do need a prescription from the doctor usually if it's that kind of garment. They also carry non-prescription garments, and some of them, it's amazing. When you go to the store, they have them, so many different varieties, and they'll help you. So look in your neighborhood or nearby for somebody who does medical supplies. And sometimes the right place. And of course, the famous web, internet can often guide you if you need help to see where you can get these. I think that's everything. One other thing on compression garments, they actually have devices that can help you put them on. They're called donning devices, DONNING, because you can don them.
Okay.
And then there's some compression with zips. So that's there's wraps. You don't actually pull anything on. You can actually wrap the extremity. And it's like wrapping an ace bandage, which is a fancy one that's got a little more ability to stay. So there's different ways of getting that compression. And that's all I have on that one.
Well, that's part of what we love about you, Dr. Patel. You realize the functionality and the practicality of everything and trying to help us better. April, you had something to say?
Yes, regarding the person who asked the question about epilepsy versus EDS, I found that question it really made my ears perk up, because my daughter, who is 20 years younger than me, she's 28 this year. When she was about 12, almost 13, she was diagnosed with epilepsy, and they didn't know if it was a childhood one or an adolescence one, because it was right there in the middle. Anyway, I found that the things that triggered her seizures were the same things that triggered me to feel really, 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 really nauseated. And so what I'm trying to say is, for the last couple of decades, watching her made me wonder, do I have something similar to whatever she has? So I find that that's something that I would really love to do research on.
Oh, yeah. Well, April, that's a good question. And usually when a patient has had any kind of seizure activity, they will have gone through neurology, and neurology does all their testing, including simple EEGs, a brainwave studies,
Right.
all the way to 24 hospital. They do all kind of stuff. They do scans, and if all that is negative, then then we look towards dysautonomia as being the cause.
Yeah,
of
and they
the
did that to me.
So in your
they did that to
yeah.
me, and everything came back fine. But
So
I still get very, like,
yeah,
if there's flashing lights, I just feel like I'm going to throw up.
yeah.
You know,
That okay. Just on a general basis, what you're describing is not uncommon at all, and that is not a seizure, complex seizure, or it's atypical migraine or
Yeah.
something. But
Okay.
really, if you look at the precipitating factors, you could have missed your hydration, electrolytes, or you could be having stressors. Because remember, one of the cardinal signs of autonomic stress is nausea. People come to us all the time, they're nauseated. And you fix all the little things, the hydration, electrolytes, and lo and behold, the nausea is better. Not always, but most of the time. And on that route, the number one and two problems we're told is chronic fatigue and mental fog. I mean, it's like I wish I knew a way of helping with that better. But
I'm also seeing, looking back at her childhood, she absolutely has mast cell activation syndrome. She absolutely has dysautonomia. She absolutely has a lot of the EDS symptoms, and she absolutely has epilepsy. So I'm just saying that to whoever asked that,
yeah,
they really might want to do some more research, because I really, in my personal opinion, from experience with my own family, I think that it could possibly be related. I'm not saying that it is. I'm just saying they might need to want to.
It's always possible to have four things, yeah, or even six, because things
Lucky you.
complicated. Yeah, it's like you don't want to be that lucky winner with the four, but you could have it. Yeah.
It looks like we have Tiffany raising her hand right now. Did you want to unmute, Kitty, and ask a question? Unmute.
Yes.
There you go.
I'm the one who asked the question about that. I think my three daughters have dysautonomia and EDS and whatever, where they haven't been tested or anything, but my grandson is 6 years old, and he's been dealing with this epilepsy for several years now, and it's a very rare form. And I remember when I had severe migraines when I was younger, and I remember seeing a doctor in Vienna actually who'd said that the scores that he had there was very close to epilepsy for the migraines, and I always wondered about that. And now he's struggling with this and he's doing a little bit better, but it's just they don't know enough about it, this particular type of epilepsy. And I just kept thinking about that. I've seen a few snippets of connection somewhere, but it just seems to me that it would be logical, that it would be.
It's a lot of medical advances actually made by observations like yours, where either the patient or the doctor or somebody kind of connects the dots and thinks, oh, wait a minute, and then they research it more. So hopefully, the world of neurology and dysautonomia, they'll all kind of do more on this. So I know there are learned meetings going on all the time where they invite specialists from different fields, and it's quite impressive to see that, yes, things are starting to move along better. But I don't have a good answer for you right now, but it sounds like for your grandchild, they should do the basics, the hydration and so on.
Yeah.
See if that helps.
And can you recommend the neurologist that is familiar with dysautonomia and EDS and all this?
Dr. Rex Hauser in Covington, he seems to at least get it, and so he's good, and I admire that he is one of the few who's actually said, oh, okay, let's make sure that it's not just a plain neurology issue, so it could be something else.
Okay.
And he's
I
a
don't know about
neurologist.
yeah, the brain, that's Rex Hauser. And there's two of them in the same practice, his brother and him. And his brother doesn't quite get dysautonomia, so don't see him.
Thank you for that information.
Because people are tempted to, I'll just see whoever is available. And it's like, no, their rule is once you see one, you see them for life. You do not change. Yeah. So do not get into the wrong one.
That's good advice.
Thank you.
Yeah.
Okay, we have another question going back to the bloating you talked about earlier due to dysautonomia. Someone asked, what can you do for this, especially when someone bloats no matter what they eat?
That's the $60,000 question, right? What do you do when everything of that individual actually does need to see hopefully they've done everything. They've seen a gastro, and they've seen a mast cell specialist, because a lot of times those reactions. However, the other thing that I would suggest is look up a low histamine diet, just to make sure that you're not inadvertently, triggering something going on there. There are medications that the physician might consider. There's something called hyoscine. Hyoscine is an old drug, but it seems to work well with calming down the bloating. There's also pill, and some of the older physicians used to use something called paregoric, which I don't think I've ever found lately, but apparently that used to work well for bloating. And I'm not even sure what's in it. So I'm not recommending it. I'm just throwing it out that if you come across it, that's one of the very older ones, which probably is restricted because they didn't do any major research on it. But sometimes the old things work real well.
You can still get that.
And
My grandmother with that one.
say that again?
Somebody asked, I'm sorry, go ahead.
No,
Somebody's talking.
I'm done with that.
So you can still get it. You just have to get doctors to write for it.
Okay, a bit like low-dose naltrexone. You got to find somebody who'll write it for you.
Right. Because it's actually a narcotic.
That's why they don't write. Yeah, because that's like Lomotil or atropine diphenoxylate. That's the generic version. It has to be. They're watching it. They think you're going to abuse it. I mean, you can't really Yeah, it's okay. You just got to use it in limit.
Yeah.
Everything
Right,
in limit.
exactly. Yeah.
But some these remedies seem to work. Even for this bloating, so basically the Pepsid with the Zysol or one of the things like Allegra, Claritin, that together with a touch of Benadryl can help sometimes. And these are non-prescription, so that's why I was just throwing those in. But you may need more stronger therapies if it's truly from mast cells, such as ketotifen or chromalin. Now that you really need the allergy immunologist to help you with that.
And somebody asked, do you recommend a particular specialist in mast cell?
I usually, in Covington, we have Dr. Qureshi, 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 who's really knows a ton of stuff, and she's amazing. And of course, she'll have a big waiting list, but she's really good if you get into her.
Could
And
you
the other
repeat her?
great
Could you repeat her spelling again? I'm sorry.
Sure, it's Qureshi, Dr. Qureshi. She's right down the street from where I am.
Okay.
And then the other one is in New Orleans, and her name is Dr. Mehta, Mehta, Mehta. And she's probably hard to get into too, because they know their stuff. But if you can get to see one of those two, they're really good. There are other allergy immunologists who understand. It's just that I haven't come across them. That's so I should let you know there are other doctors who kind of understand. The problem
We
is
appreciate you sharing those two names. Just as a side note, going back to the compression socks, we had two comments. Carmen said she found a compression sock that has zippers. It's on the Dysautonomia website under shop. She'll post it later. She says perfect for the car. And somebody else said Old Navy Active Soft are the best compression leggings they have found. So just a little aside on that. And I'm getting lots of messages. Thank you so much for doing all this. But we do have two more questions, and I'm trying to find the one that I'm gonna have to go back to find that one. Someone said, how do you determine at what point to go on disability and to, I guess, let go of the dream or the goal of being able to work anymore and say, okay, I've done enough. I've tried enough ways to get past this. How do you know when it is time?
well, usually your body tells you, you're like, I've done everything. But our goal usually for our patients is to get them to where they're functional for their daily life, and eventually if they can get back to work. But it's very tricky. Everybody's different, and some of it's, I see that the patients really work hard at it. They almost work too hard at trying to get better, and in fact, they're doing themselves a disservice sometimes. You have to pull them back and say, you really need to back off a little, let your body recover in steps. And others, they kind of just, they tried everything and nothing works. So they'll say, what should I apply for disability? And if it looks like a situation which they're not going to go back, I would encourage them to go ahead, and because it's a long process and often gets denied. And I believe you had an excellent speaker the other night who went into all that. And I wish I'd been there, but I was not able to see her talk. But anyway, Terry Gross does a great job with that, and she's overwhelmed, of course. But there are a lot of disability attorneys. Some are really good, and they will help you along the way, and others kind of let you do all the work. There's even a national service. I don't know how good they are, but some patients have told me it's called Citizens Disability. They're all over the country. So when do you go to them is really when you're like, okay, I think I'm done. But you also need to know that you need your doctor's support. And you got to let them know, because guess what? These folks, when they do the reviews, they're looking at the doctor's notes. And if you're having glowing reports doing well, it's not going to work. So you got to let the doctors know so they can write down your symptoms and kind of assess you and say, oh, they want you to be able to lift 10-pound weights, 50-pound weights, or climb ladders, because that's going through my mind when they're saying disability. I'm thinking, okay, no, 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 yes, no, because eventually that's what the forms ask us, and we got to kind of have an idea. Now, if you're kind of not sure and you're equivocal, it gets tricky, especially if you already have an employer. In that situation, I always suggest try doing intermediate disability, like do FMLA, or see if the employer will allow some accommodations. And if you are lucky enough to have like a short-term disability, can go on to that to see how you do without the pressure of work on you. Sometimes that's enough to get you recovered within a matter of 6 to 12 months, to where you can say, okay, I'm done. Or if you don't, then usually the disability company wants you to say, oh, we've had enough of you, we're going to put you onto Social Security. So none of them is trying to keep you on there. So you got to remember, you're not the problem. It's just the system is pushing to keep people out. And if you deserve it, you deserve it. So you have to fight for it tooth and nail. It's exhausting because you're already exhausted, tired, you have mental fog, you can't remember zip. And now they're asking you to all these papers to fill. Yeah, and oh, by the way, I apologize to all those people waiting on your paperwork. I am so far behind. It's just no time left. Things, but I'm working on it. I promise you, I'm working on it. So I do them as best as I can. And the problem is I do them in a way where they don't back against the patient. So that's why it takes time rather than just quickly writing out a form. I try to give you a concrete reason why we're saying whatever we're saying, right?
We know how
So
much
that
you
was your
do for all of us. Thank you, Dr. Patel. We know you give your heart and your soul to everybody. And over and over again in the chat, people are putting comments. Thank you, thank you, thank you. Someone said, you're speaking to my soul tonight. You do so much for us. So everybody so appreciates the time, dedication, concern you show to all of us with dysautonomia.
Absolutely,
and POTS and EDS. So thank you. And here you're sharing your night with us as well after a long day at work. You're amazing. Thank you. Everybody's saying there need to be more doctors like you, and we agree. Although we think you're 1 in a billion, I don't think we can replicate you, but we need something close to you so you're not so overtaxed and you can be there for your family.
Thank you, thank you. It's just yeah, it's always you got to put the patients first. So my family knows they sacrifice many hours of me not being there, but they worry about me working so hard. And I'm like, you know what? It's not really work when people are really being helped, and
they're just so special.
Yeah, so it just helps. It's just there's more reward in helping people than anything else. So that's what I do, and I'll keep doing it while I can.
We feel it when you sit there and listen to us. And you take your time with us. We really do feel it, and thank your family. Wanda, did you have a quick question? Because we were trying to wrap everything up. I don't want to leave anybody out. Wanda?
Yes, I do have a quick question. The question is I've been experiencing, Dr. Patel, a lot of optical something with my eyes, migraines. And I just want to know, is that something pertaining to my dysautonomia?
That's a good question. It's kind of tricky without getting into personal medical details for you, but in general, when you having a lot of migraines, it can actually be just a flare in your autonomic issues. An optical migraine, for those who may not be aware, is where you excuse me. Oh, I think that's my wife saying get off, but I'll call it back in a minute. Are you done yet? No, it's okay. So an optical migraine is essentially from when the optical cortex, which is in the back of your head, isn't getting sufficient, either isn't getting enough blood supply, or there's something there that's irritating it. And in my way of thinking, it's like, all right, if you're not getting enough going there, because it's kind of far away from the big pipes, the carotid arteries that are taking the blood to your brain, is kind of a long ways to that little piece way back there. Maybe it's just a temporary shortage of blood flow that's triggering the migraine. And once that happens, all the what you call it, the brain waves get triggered, and they can start off the migraine. Now, I don't know enough on the neurology side to see if there's a different explanation. But to me, it just sounds like you need to probably, if you're having more migraines, you need to definitely hit the hydration, electrolytes. And oh yes, for all of you out there, you need to know this is October month, which is also when we have the October effect, where a lot of our patients seem to decompensate because of the change in temperature, barometric pressure, pressures of taking the kids to school, a new job, whatever. And then they don't feel better till January or February because there's ongoing social stress, things to do, got to get it done before the end of the year. So that can be triggering migraines too. So everything is interrelated to the environment, things that you're doing, and things you might be forgetting. You might be forgetting to, you think you're hydrating, and then you actually look at it, you're like, oh, you know what, I'm missing out. I need to do more. So look into what you're doing, and we can talk in the office later.
Okay.
Well, thank you so much.
You're welcome.
We appreciate you. We appreciate your family, and we hope this has been beneficial to all of our participants. It is so late, and we still have 36 people on. I think it's amazing. It just goes to show how much everybody needs to hear what you are telling us, and we hope medical professionals will listen to this as well, because that's one thing we all are faced with, people not understanding. Carmen, April, did you have anything else that you needed to add?
No, just again, thank you so much. We could never say thank you enough.
It's a wonderful way to celebrate Dysautonomia Month to have you here, Dr. Patel.
Thank you all. I really appreciate the opportunity, and thank you, Carmen. And I think we can all go and have our dinner or whatever you all want to do. But we'll keep working at it, and we will educate more people with this. All right.
And we love the cooperative effort of EDS Louisiana with Dysautonomia Louisiana. Thank you, Carmen, for helping us out with this. And thank you for getting the Superdome to light up.
That was
let the whole world know
phenomenal.
about dysautonomia. Thank you.
Amazing.
I so wish all of you could have seen that. That is so breathtaking and so emotional. Like it just, until you see it for yourself and you're under that big light and you know they're shining that for us, you got to be there.
Right. And thank you, Dr. Patel, for continuing to shine the light on all these issues for us with dysautonomia. And you're putting it all together, and you're validating and giving hope. We truly, truly appreciate it.
All right. Well, see you all, and you all have a great evening.
You have a good evening too. Thank you, everybody, for joining us tonight. Look
Thank you
forward
so
to
much.
other seminars that we'll be posting. Stay tuned.
Thank you, Dr. Patel.
You're welcome. Thank you all. Thank you. Thank you.
Good night.
Thank you. Good
Good
night.
night.
Good night.